We're going to turn our attention to a topic that has been brought up multiple times over the course of the day and a half of discussion, and I think it's a perfect time after the lengthy discussions we just had on incentives, cultural issues, etc. And this is the topic of facilitating patient ownership of clinical trial data, both challenges and opportunities. So the format will be two 15-minute presentations by people thinking and working in the area, followed by 15 minutes of a panel discussion. So first, it's a pleasure to introduce John Wilbanks, who's the Director of Sage Bionetworks, and John will be leading off this session.
So I'd like to thank the Institute for the chance to speak, and Sharon in particular for putting me on the agenda. So you can go ahead and advance. So I have this session's on patient-driven sharing of clinical research data, and I actually changed my slides pretty much completely last night after following the tweet streams and the discussion of the conference. And the first thing I want to think about is what I think of as clinical and what you think of as clinical may be very different. And so to me, clinical means basically anything that might be clinically actionable. And that includes CLIA-certified data. It might also include lifestyle data about what I do, when I do it, where I do it. And so we need to think about things beyond just CLIA. In terms of research, again, a lot of research can happen outside the traditional medical industrial complex. There's an enormous power for computational researchers coming from outside the life sciences to do powerful computational research. But right now, because of the credentialing process, the data standards problems, the privacy problems, it's basically has a giant stop sign in front of it if you're not part of the existing system. So it's if you're a data scientist, your research for the most part happens in mobile, it happens in social, it happens in finance, it doesn't happen in health. And given that we're facing a gap of 250,000 data scientists over the next 5 years, according to McKinsey, the last thing we should be doing is putting block points in front of computational researchers who actually want to work on this stuff. And then last is what do you actually mean by data? And I'm going to talk about that in a little bit. So this is a picture of the folders at my pediatrician's office, the medical records there. And so this is when I talk to a lot of people in the system, they think, well, this is data, and all we need to do is digitize it, and we'll have plenty of data, and everything will be fine. And this is a very incremental way of thinking, and incrementalism can be very powerful if you have the right central metaphor. But I would argue that thinking from the medical record from the perspective of a patient is the wrong central metaphor. Incrementalism, and when I can click this myself, it's better, I promise. One way to think about incrementalism, and I got this from the professor I worked for at MIT, is think about your ear as an information gathering technology that pulls sounds out of the world. It's a very effective information gathering technology. Let's go through two more. And so incremental advances on it, right, get you things like the ear horn, right, and then here. And so when I see an EPIC system, right, this is what I see, because it's basically a massive, powerful incremental improvement on a fundamentally incorrect central metaphor. Because it's thinking about episodic interventions in which I see a doctor, not about a longitudinal map of my health and my life. And we have the capacity, thanks to ubiquitous sensors, cell phones, and all sorts of other technologies, to actually get a much more high-resolution picture of what people live through, right? Not just what we treat them for episodically, or we study in the context of a single clinical study. So clinical research data can come from places that are not traditional clinical research studies. And in fact, it has to come from those, because that's what people who are sick are going to be collecting about themselves, whether or not they're in a traditional clinical research study. And then I was trying to think of a way to express the central metaphor of health data sharing. And I couldn't remember the last time I heard the phrase fax machine anywhere outside of the system. So when we think about sharing in software, sharing in culture, we share through networked technologies that have an open set of protocols at their core. So the system was tilted towards copying, editing, redistributing, and sharing in a way that was pretty tough to undo, despite the best efforts of the music industry and the video industry and so forth. Now, when it comes to patients, right, we're not very patient. as people. And so this is something I did, I started a week ago as an experiment to see what would happen if I put my genotype online. So I got genotyped at 23andMe. I posted it. This is what you see right now if you go to 23andMe. So I'm not really that interested in my cilantro quotient. But what I'd like to know is, and again, 23andMe, great service. They let you download your data. Right? I beat up on them a lot, but I'd like to give them credit for letting me download easily my genotype file. So I uploaded it first to the Sage BioNetwork's Synapse repository. So this is, you can see I've been assigned a unique identifier. I'm telling you that one's me. I don't really care too much about that. I went through an informed consent process that I'll show you digitally that allowed me to upload that file and syndicate it over into a computational research environment. So this is intended to be essentially a fire hose that can attract data science researchers who know that the data that's in there is standard format. It's been cleared from a privacy perspective. They can come in and do data-driven research on it. They can do version control on what they're doing and basically do collaborative data-driven research. And nothing like that really exists right now in the life sciences. And this is the actual individual page. And so this is what we've designed at Sage as a way to share individual level information, because I'm not that interested in aggregate information. I'm interested in serving as a genetic control for psoriatic arthritis, right, as an individual. I'm interested in getting advice on what to do with my cholesterol as an individual, not in the aggregate. It matters to me what happens to my individual data. Now, this is a very traditional system in many ways. It's an online version of a traditional way of getting people in. But I wanted to try something else, so I uploaded it to another website, which is called OpenSNP. This is a wiki based in Europe that a postdoc threw up that you can add your genotype to with basically you click on an OK for the consent process and you upload it. Now, and they give you an, it's obviously not a picture of me, they give you an automated avatar and an automated page. And what happened, and again, I did this over the weekend, and so it was really interesting what's happened in the last 5 days. So it got syndicated over to a different wiki called Snippedia, which a guy named Mike Cariaso runs, and it runs an automated gene annotation report for you. So I got an email. All I do is put my stuff on a wiki, and 2 days later I get an email with an annotation of my genotype that has novel annotations I've never seen before, including at 23andMe. The biggest one is the increased risk of hypertension. All right, so, and there's a citation to it, right? There's all sorts of interesting information. It's completely happening outside of any sort of regulated DTC system, right? It's happening algorithmically, and you're just getting emails through anonymous remailer interfaces on wikis and websites. And so I'm psyched about the hypertension. I'm not psyched about hypertension. I'm pretty psyched about not going bald. But I mean, just look at, this is what happens when you're not patient, right? If you basically say, screw the system, it's not serving me, I'm going to put my data up, right? This is the sort of good thing that can happen. And I'm not promoting this because I think this is the state of the art or what I think everyone should be basing their medical and health decisions on, right? I would rather see the health system be doing this for me than doing this through algorithmic systems and wikis. But I'm not getting the service from the health system as an individual. And my capacity as an individual to generate data about myself is exploding. My capacity to use the systems I use to share software and photographs is exploding. And things will emerge to serve me, whether they come out of the existing system or not. And I strongly prefer that it comes out of the medical system because I believe in the power of the training of the system. But it's just not happening at the same rate of change that culture's happening. This is one of the funniest things I got. This was from a genetic genealogist in the UK. So this looks for rare and uncommon SNPs. I've only got one homozygous recessive. It appears to be unlikely in terms of significance. But the best was, this guy's a genealogist, and so this was in the email that he sent me, unsolicited. And I'm from Tennessee, so this was really good news. So this is the point, right? I'm increasingly able to access data about myself, whether it's through Blue Button on my electronic medical record, or by getting my genotype done, or by running any number of services that are out there in a marketplace that allow me to generate data about myself. I'm able to distribute them, and there are people, which I didn't even know, who are out there looking at that data, interpreting it, and returning me results just through email. And if you think it's just genotyping, right, think about the overinvestment in core genomic services at land-grant universities over the last 10 years and the cutbacks in funding, which mean that those machines are going empty. So this is a company, a startup company called Science Exchange in the Bay Area that's created an online marketplace where anyone, right, I don't have to be credentialed to use this, can commission at the lowest bidder any number of traditional clinical services that used to be the province of the system. So this is what's the rate of change in culture that's happening in places that are not the National Academies, the Institute of Medicine, and the National Institutes of Health. And people who are frustrated are increasingly going to find these services and start using them. So I'd like to lay out some proposed principles for sharing, because we don't have the internet for health. We don't have TCP/IP and HTTP. We don't have site certificates and HTTP secure. We don't have a culture. We don't have norms. Right? And we have legislation that is contradictory at best. And there's this understanding that by sharing more that we can get research results better, but there's also real risks from a privacy perspective if we do this wrong. So the principles that I'd like to propose are fairly simple, which is that we need to be honest with people. We need to tell them if you opt into a shared clinical system where the data is at least moderately public, that it is unlikely that their privacy is permanently protected. You know, I don't believe that it's 3 data points that re-identifies you, like LaTanya Sweeney says, but I heard earlier this week at Mount Sinai that there's 500,000 data points in your health record. I think that's plenty. Even if we take out information, we need to be honest about that and say, if you'd like to share your data, you need to understand that there are risks. And we need to have some risk tolerance as a society for the people who think that the value of sharing their data is greater than the risk that they face. And I would like to see some safe harbors for those people as well as for those who do research with their data. I think we need to focus on the reusability of the data, not just posting it. I got my health records from my doctor. They were scans. Right? They're not reusable. They're not computationally useful. And portability, which means I need to be able to take all of my data from one company to another company to another company as I need to, from doctor to doctor, from lab to lab, and from study to study, because then we can take the cohort from one study that's a good genetic control for psoriatic arthritis and reuse large chunks of it as a cohort control for rheumatoid arthritis. It begins to accelerate the system exponentially. Now, I'm at Sage BioNetworks half-time. I'm also at the Kauffman Foundation for Entrepreneurship half-time. I'm going to show you some stuff from Sage. This is Synapse. It's a back-end system for storage, version control, and collaborative work on computational biology. We're doing several contests right now, which I'll show you the results of at least one of them. But this is a place where you can start putting your data if you've actually been honest with your users and you want it to be reusable and portable. So you can't say anymore there's nowhere for it to go. Right? That excuse is now off the table. If you can't put it in CBI, you can put it here. Consent is also something that we at least have a couple of answers for. This is a consent system we've built, which allows people who have data about themselves to donate it to research. And Kelly was part of the ethics advisory team that helped us put this together. You go through an online wizard, you grant explicit rights to do research, to publish, to redistribute to people who have signed the same terms of use, and even to commercialize products. You can't sell the data, but you can sell products, software, drugs, diagnostics that come out of the data. Right? This is a donation of data, not a conditional grant. This is the sort of things you see when you have a consent infrastructure and a computational infrastructure. We got a bunch of data from and cell lines from Metabrick on breast cancer. We turned 1,000 of those into a data set. We invited the world to come in and build computational models of breast cancer. And now you see the leaderboard at the current, as of late August, for people submitting. And, you know, Warwick Systems Biology is someone you might expect to see, but there's also people just coming in randomly who are building better and better computational models of breast cancer. And at the end, we're going to have all the models, not just the winning model. So we're going to be able to learn from all of the failed attempts, not just all the successful attempts. And Bridge, which is the newest piece of the Sage system, is a way to actually let people who've got data about themselves come together and commission people to come build the models. So this would allow 50 people with early onset Parkinson's to come in and say, we've got genomics data, we've got all sorts of other omics data, we've got metabolic and molecular data. It's in a standard format, $50,000 prize to the first person who builds a successful computational model. The breast cancer project I just showed you is a part of this. And in Fanconi anemia, we're looking at what happens if you actually build a private system for sharing data about minors, obviously, and we start looking at what's the relationship between Fanconi anemia and head and neck cancer. Again, letting people come in, credential, watch what they do, but basically lowering the barriers to get at the data to do computational research. And the idea is that you ought to be able to give money to a thing like this directly, you ought to be able to give data to a thing like this directly, and you ought to be able to contribute as a competitor directly. And changing the roles is sort of the third piece. You need the back-end software, you need the consent, and you need something that begins to change the roles so it's not just, I'm a patient and I see my doctor X number of times a year. You can be a participant. So to sort of end this and let you think about SAGE, sorry, one more. The idea is that the whole point of this is scale. If we have 100 patient-driven clinical studies that don't connect and don't integrate and don't scale, we will have missed an enormous opportunity. And if we actually implement things like honesty, reusability, and portability, at some point we're going to change a clinical outcome. We're going to change a decision. And the way that we do it really affects whether we affect the clinical choice through absence, right, or through presence. And right now, the only way that most of the stuff that's happening out of the NIH affects clinical outcomes is through its absence, because the articles can't be read, the data can't be accessed, and we're not letting the world come in and figure things out about it. It's not easy. It's not that there are no implications, right? But the complexity of the problems we're facing is so large that it's a tragedy to me that we're not inviting all the data scientists in the world to come hammer on it. And so that's the reason I want to do what I do. Is I have a sister who's a cancer survivor and a mother-in-law who's a cancer survivor. And they're both a lot less worried about their privacy than which of the lanes they're going to be on.